Good afternoon, everyone. This is Ramesh Sachdeva, and on behalf of the BPS, would like to welcome all of you for our research spotlight session. We have a very interesting topic, and before we get into that, it's a real privilege to introduce our speaker this afternoon, Dr. Javier Lasa, who is an associate professor of critical care cardiology at the University of Texas Southwestern Children's Medical Center in Dallas, Texas. Dr. Lasa is a cardiac intensivist, and in addition has this unique role as the executive director for informatics and innovation core in the Heart Center in Dallas at the Children's Medical Center. Dr. Lasa has a very impressive CV, and just want to point out that in addition to being a cardiologist, a pediatrician, cardiologist, intensivist, is also board certified in medical informatics. And I just learned that he was on call last night. So really appreciate your taking the time post-call to share some of your findings from a really interesting study published using the VPS database system, critical care unit characteristics, and extracorporeal cardiopulmonary resuscitation survival and outcomes in the pediatric cardiac population. As we get started, would encourage all of you to please put your questions in the chat box so we can address those after the brief presentation. Without any delay, please join me in welcoming Dr. Lasa.
Fantastic. Thank you so much, Dr. Sachdeva. I'm going to go ahead and share my screen now. And make sure everyone's seeing this. Give me a thumbs up if you're seeing my screen. Or I can't see thumbs, actually. So everyone okay? Just give me a voice that this is what you're seeing.
I can see it.
Perfect. Thank you so much, Alex. All right. Well, thank you again for the opportunity to come present the results of our recent pediatric critical care medicine manuscript that was accepted last year. We're excited to review the results of this, as it was both rewarding but also quite challenging analysis, but one that I think is going to help us move forward in terms of our understanding of risk factors for survival in this very challenging population. And so on behalf of my author, my co-authors, Dr. Bilala, Dr. Thiagarajan, and Danielle, excited to present these results. I hope some of those co-authors are able to hop on the call. If not, we're going to move forward. I don't have any formal disclosures or conflicts of interest in relationship to this program or presentation. I'd like to follow just a very traditional outline for the presentation, one that you would see in typical abstract presentations with a background, methods, results, and discussion, but hopefully peppering it with some of our prior research and also providing opportunities for questions. And I think this is a fairly savvy group to not have to review the definitions, but just in case, what is eCPR? And eCPR stands for Extracorporeal Cardiopulmonary Resuscitation, really the use of ECMO during active CPR. Typical indications are for refractory cardiac arrest, and it's always deployed during active CPR, although current consensus definitions across international resuscitation guideline groups, as well as the Extracorporeal Life Support Organization, or ELSO, will define a case as eCPR if you are cannulating onto ECMO within the first 20 minutes after ROSC, as that 20-minute mark has been accepted as a definition for true sustained return of circulation. Again, the mode for eCPR is most commonly veno-arterial. There have been some reported cases of VV eCPR, but the vast majority, especially in the pediatric population, is going to be VA. Now, why I'm demonstrating this rescue or space map for eCPR is because it really highlights exactly how challenging this interdisciplinary therapy is, and really defines and puts at the center of the patient. And I think it's very often hard for us when we're in these chaotic environments to remember that we have a patient in the center. When we're trying to set up the ECMO tray, the surgeon's getting prepared to cannulate, you're trying to figure out who's doing what role. And really, eCPR comes down to that complex team choreography and, of course, the one given that has to be present in order for success, which is high-quality CPR. But it's that second piece, that complex team choreography, that fascinated me and my co-authors and led to some of the hypothesis generation that led to this study. So Background information, pediatric eCPR utilization from ELSO showed a significant rise up until really the pandemic, and it has plateaued since then, both for neonates and pediatrics. But what's most striking is the fact that our survival rates for both pediatric and neonatal eCPR has unfortunately remained flat. And this is really what gets to me the most in terms of why I'm doing research in eCPRs. What can we do to help move this survival trend in an upward direction? And so how do we improve those outcomes? Do we focus on those patient-level characteristics that are sometimes, most often, not modifiable? Do we focus on that complex team choreography, that interplay that happens in the actual performance of eCPR? Or do we focus more on the way the system is set up and the way the teams work? More than just the interventional choreography, but really how do we work together? What are the support structures? What's the culture? And it's this last bottom group on the right that I'm excited to try and explore a little bit more about. eCPR has been utilized across patient populations, but the cardiac patients tend to be the ones who have utilized it the most in the pediatric world, going all the way back to Dr. Bartlett's first cases in the 70s, where he described eCPR for cardiopulmonary failure in post-congenital heart disease cases, all the way up to Dr. Del Nito's landmark first publication in 1992, looking at eCPR after congenital cardiac surgery. In 2016, we published a large analysis comparing eCPR against conventional CPR utilizing the AHA's Get With the Guidelines Resuscitation Registry. It was a large study. We were able to demonstrate that the majority of eCPR was within the cardiac illness category patient population, 79%. We demonstrated that there was approximately 40% survival to discharge with eCPR, which was better than conventional CPR. And after controlling for patient-level factors as well as hospital size, geography, and teaching status, we also demonstrated that eCPR had demonstrated better survival with favorable neurologic outcomes as well. eCPR is utilized in our cardiac ICUs right now. Approximately 28% of cardiac arrests deploy eCPR in the contemporary cardiac critical care population in North America. These are two studies from the PC4, or Pediatric Cardiac Critical Care Consortium, that have demonstrated epidemiologically the current utilization. In fact, 34% of all ECMO runs are eCPR, with an approximate survival to hospital discharge rate of 38.6, at least in this current registry. And a lot has been done to try and understand outcomes in relationship to what happens after you're on ECMO. And I think this is an important avenue of research, undoubtedly, in the timeline of cardiac arrest onto ECMO, where you have your pre-arrest state, your no flow, beginning into low flow state with active CPR until you're finally cannulated onto ECMO and you go from a low to a high flow state. We know that persistent lactate levels, renal injury, and post-ECMO complications related to bleeding and CNS injury are all associated with worsening mortality. But what about the timing prior to cannulation? This is important, and I'm going to call it a golden hour. This is the golden hour in reference to some of the trauma literature that says this period of time, both pre-arrest, but also during that active CPR to cannulation period, is very important for our patients and should be a focus of more of our research, in my opinion. What are those pre-cannulation factors that are associated with mortality? Well, non-cardiac patients have unfortunately been shown to have much poorer results than cardiac patients, although there was a recent paper published in PCCM using Bayesian analyses and utilizing the Get With the Guidelines Resuscitation Registry that demonstrated that there was potentially some benefit to eCPR, but the jury is still out. We know that the last pH before going onto ECMO, at least during CPR, can be associated with increased mortality, as well as lactate and any pre-existing renal injury. And of course, the collinear important CPR duration that has been shown to be associated with worse outcomes for eCPR patients. I would also venture to say that any residual lesions, this is speaking to the cardiologists in the group, any residual lesions like profound or severe aortic insufficiency will make ECMO virtually meaningless because you're not going to be able to flow. But I'm going to ask the question to the group. What about how the organization is set up, the ICU structure, the type, and the personnel that are working in this tandem complex choreography? Location matters. In North America, the majority of eCPR occurs in cardiac patients. I've mentioned that, but we're seeing a change in the demographics of the types of ICUs. This is data presented from the PC4 site survey. It's unpublished, but still free to present to the group. We surveyed all of the PC4 centers, 100% response rate, and asked them, what kind of a unit do you work in? And early on in the collaborative, we had vast majority were dedicated cardiac ICUs. But as you see here, we're seeing a trend towards mixed units. Others here are also described here as units that may have acuity adaptable units crossing both populations. But what we're seeing here is we're seeing a downtrend in dedicated ICUs. And so it begs the question, what does that mean for our patients who have cardiac disease? I took this line of reasoning one step further and utilized some of the PC4 site survey data to look at incidents of cardiac arrest and to say, are there any critical care unit organizational personnel factors that may impact just the incidence of cardiac arrest? And what do we find? We found that indeed patient factors and arrest event characteristics definitely impact the epidemiology and survival outcomes from cardiac arrest. But we asked about staffing models, educational background, and ancillary support staffing. And what we found was that there were strong associations with cardiac arrest prevention when you looked at things like average ICU bed occupancy and nursing experience. And so what were we aiming to do? We were looking to look at both patient level and ICU level characteristics on outcomes after eCPR in the pediatric cardiac population, aiming to leverage the VPS data set for both cardiac and mixed pediatric ICUs to understand the impact of patient and hospital level characteristics on outcomes. And so we included all encounters in VPS from 2010 through the end of 2018 in patients less than 18 years of age. All encounters submitted to VPS where ECMO or cardiopulmonary bypass were initiated within 2 hours of initiation of CPR. Why do we do this? Well, eCPR is not listed as a unique procedure or event in VPS. And so CPR is captured as a procedure type that is defined as having chest compressions and or defibrillations. And those start and stop times are relative to the admission time, if the admission time is known. And so cardiopulmonary bypass and ECMO are both listed as procedure types with similar start and stop times. And so this made it a pragmatic definition and capture of patients. We excluded trauma or traumatic cardiac arrest and ECMO cases that occurred 2 hours after CPR start time. Our ICU types were categorized as either a dedicated CICU or combined PICU mixed type. And those were defined as an ICU in which children with both cardiac and non-cardiac illnesses are cared for by the same medical team in the same space. What were the ICU level factors we looked at? Well, VPS is able to provide us licensed bed capacity, average annual ICU admission volume, training program status, and their region or geography. Our primary outcome was survival to hospital discharge. We defined and characterized our patients using a typical chi-square test and Fisher's exact test. Independent and multivariable modeling was used trying to correlate for patient and hospital level characteristics. And we're trying to ultimately find associations between characteristics and cardiac groups and survival. Our primary exposure was therefore ICU type. And we started with a very large number of ICU admissions to this robust data set, 1 million admissions covering 734,000 patients. Amongst those, there were 12,931 arrest events in 11,853 patients, of which of those 671 were eCPR. So quite a small number out of the total admissions that was occurring in 650 patients. We looked at the index events. So if the same patient had multiple eCPR, we only looked at the index event, and that follows common Utstein-style resuscitation registry methodologies. And amongst those 671 events, 222 occurred in a cardiac ICU, and the remainder occurred in those mixed ICUs, PICUs, with a 67% to 33% breakdown. Amongst these index events, the illness categories for the cardiac patients were 60-40 split, with the majority being surgical patients, and surgical cardiac disease was defined as having had cardiac surgical procedure immediately before or any point in time prior to the arrest event during the same hospitalization or during the same ICU encounter, excuse me. We had a majority infants and neonates, 41% neonates and 38% infants, with a smaller group of children and adolescents, slight male preponderance, and the definition of congenital heart disease as a characteristic was found in about 84% of the patients, which begs the question of sort of how are the other patients defined if they were still medical cardiac, and those may have been acquired conditions. For the total cohort, these are the numbers in terms of weight. Median CPR duration for the cohort was 45 minutes. ECMO duration here in terms of hours, mechanical ventilation, and length of stay for the overall cohort. These tables are taken directly from the PCCM manuscript. Obviously, there's a lot of rows here, but this is describing the overall cohort as well as the cardiac ICU mixed units exposures to understand differences between the two. I'll highlight some differences here. In particular, there were no differences statistically between the CICU mixed groups for weight, for the breakdown of ages or gender. CPR duration was different. Notable was the fact that the mixed PICUs had slightly shorter CPR durations, with the p-value shown here. There were no differences in terms of these events occurring at nighttime between the units, but there was a much higher proportion of the mixed ICUs that were larger than 20 beds for licensed bed capacity than there were for the CICU or dedicated groups. So it looks like CICU groups tended to be smaller licensed bed capacities in VPS, while the PICU mixed groups were larger. And as you see here, there's also a difference in annual ICU admission volume average, with the cardiac ICU dedicated units showing to have less annual ICU admission volumes than the mixed units. Overall survival to hospital for our results was 51%. That's quite impressive for the VPS registry. Differences in CPR duration we've already highlighted. And in terms of the ECMO duration, these are the differences between the two. There were no differences otherwise, and no statistically significant difference in survival discharge between the two groups. As you see here, nearly 51% and 51% survival for both CICU and mixed groups. Now, on independent logistic regression, we found that surgical patient category was associated with improved survival or higher odds of survival in comparison to the medical population. This is quite consistent with current literature and prior literature demonstrating that medical cardiac patients tend to have poor survival after eCPR. And as we're learning even more recently, that those with and without congenital heart disease have differential survival characteristics. And so there's more research ongoing to try and understand the medical patient population. With regards to comorbidities captured by VPS, patients with congenital heart disease were found to have a lower odds ratio for survival. Similar for neurologic complications, but patients who had a respiratory comorbidity as a potential reason for admission tended to have higher odds of survival. And there was borderline differences here for eCPR occurring at night and for licensed bed capacity greater than 20, demonstrating a poor survival or lower odds ratio of survival in comparison to those with less than or equal to 20 beds. But on multivariable logistic regression, what do we find? We find absolutely no association with survival for ICU type. Although we did find that for ICU beds that were greater than 20, in comparison to those that were less than or equal to 20, was associated with decreased odds for survival, even on multivariable regression. What we did find was that patient and event characteristics are strongly associated with survival. Namely, if you're a surgical patient, much higher likelihood of survival in comparison to medical patients. If you're experiencing an eCPR event at night in comparison to the day, there's lower odds of survival. If you're there for respiratory reasons and you happen to have an arrest onto ECMO, you do better. But if you're there and you have neurologic comorbidities and or congenital heart disease, you do worse. And so for our discussion, survival discharge is not affected by age, gender, weight, ICU bed capacity, geography, the academic status. But again, patient level factors potentially outweigh those ICU level factors, at least in this analysis. And there were some limitations to this analysis. Of course, this is observational quality improvement registry data for ICU only events. And so this did not capture eCPR events occurring in the cath lab suite, in the emergency room, or outside of the ICU environment. We described some of the pragmatic limitations of how we define eCPR utilizing this data set. We did not utilize some of the typical risk adjustment models, including PIM and PLODs, and we'll go over that afterwards if questions arise. And again, it's very different to try and compare mixed ICUs and cardiac patient populations, given some of the limitations of those risk models. And then, of course, there are many unmeasured markers of CPR quality and post-resuscitation care and complications that are not captured by this and may influence and impact the post-ECMO period of time. So in conclusion, the overall prevalence of eCPR in children with cardiac disease in the VPS database is low. There's notable variability in prevalence across ICU types of varying type, admission volume, geography, and academic standing. We found patient-level characteristics impact survival to hospital discharge much more than ICU-level characteristics, at least those captured here. And our understanding of unmeasured organizational factors impacting outcomes remains limited. And so I'll stop there and thank the organizers for this and open it up for discussion. I'm looking forward to questions and to hearing from the group. Thank you.
So Dr. Lasa, as the participants add to the questions, I had just one or two questions for you initially. One is that what's next from this study? Where are you taking this moving forward?
Good question. You know, how we capture information that is often unmeasured is the key in any research effort, right? And so VPS has the ability to potentially ask questions that are focused on organizational personnel factors. That's something that I have not approached the group with, but as a member of the PC4 cardiac specific registry and consortium, we have expanded our site survey and are utilizing that site survey for research to try and pair those reported values that they're giving us in terms of average number of nursing hours per day, number of physicians trained in this specialty versus that, who's on call at night, what's coverage like, do you have dedicated nutritionists, dedicated pharmacists? Those are all questions we're asking of the PC4 consortium, and then pairing that with clinical patient level characteristics and outcomes.
Great, thank you. A question in the chat box from Dr. Mike McCrory from Wake Forest. Did you consider whether the center does cardiac surgery at all in your analysis?
Yeah, good question. And it kind of gets to how we are going to attempt to risk adjust. And so centers that may not have had cardiac surgery were not included in this analysis. Again, we are with the 60-40 split of majority being cardiac surgical patient population. That's indeed what we found.
Great, thanks. You know, I had another question too, Dr. Lasa. If you were, you know, for our participants who are maybe considering doing a similar study at their center or facilitating a similar research investigation, any lessons learned? If you were going to redo the study again, any barriers that you had, how you overcame those, and that could benefit the group?
I think understanding the data set is key for any research process. And so as someone who wasn't very familiar with VPS at the start of this, it took me a while to understand exactly how things were described, how we're defined. And again, how we defined eCPR was quite challenging, right? So we had to find patients who had an arrest event. Their start time was measured in comparison to an admission time. And then they had a separate procedure sheet that told us whether they had ECMO or cardiopulmonary bypass, and started to make those links. So that was that tripped us up just a little bit. I also think that for dedicated cardiac patient population analyses, trying to ensure that we're doing appropriate risk adjustment, is important. And so I have some supplementary slides here just to kind of carry that thought. And so we initially did not do any risk adjustment using the PLOT and PRISM-3 that are provided by VPS. Mostly because there's been data to suggest that there's poor correlation between them and validated cardiac surgical risk adjustment tools, such as the STAT category. And unfortunately, Dr. Rice and team's PICSIM, or and Dr. Jeffries, of course, their pediatric index of cardiac surgical intensive care mortality wasn't available at the time of our analysis. But we ended up, just because the reviewers had asked for this, we ended up doing a post hoc independent regression that found no association between PIM2 and PRISM-3 and survival discharge for our patients. Now, what about the surgical patients in our group? We ended up, just for the sake of transparency, showing the breakdown of STAT categories for those cardiac surgical patients included in the analysis. And as you see here, 42% were STAT 4 category patients, 29% were STAT 5. So these are some of the highest risk STAT category, and those were the majority here. So these were pretty complex surgeries happening across the VPS registry sites. And on independent logistic regression and sort of grouping patients who had STAT 4s and 5s together as high risk, STAT 1 to 3 as low risk, and including those with missing scores, and comparing them to the cardiac medical group, we ended up finding the following associations here. And ultimately, what does this mean? That means that surgical patients are sicker than the medical patients. And so this really didn't change the results of our study when we looked at STAT category.
Great, thank you. You may already have addressed this question part, but Arado from VPS has a question on the same issue, that what are given the limitations of PIM3 and PRISM-3, what risk tool would you use instead? I mean, what should an investigator do in the future?
Yeah, I'm gonna recommend that any analysis that looks at cardiac patients really start to stratify by surgery or not. We're learning a lot more now about the cardiac medical population. These are patients who may be admitted with acute decompensated heart failure or compensated heart failure, patients with pulmonary vein stenosis that may not have had surgery immediately before or during that ICU encounter, but are still quite sick. Patients with acquired heart diseases with maybe sort of a burnt out cardiomyopathy or myocarditis. These are patients who are really high risk. And as we learn, especially from the recent cardiac arrest prevention trial, that these patients may be at similar risk for an arrest as the surgical patients, but do poorly after their arrest, and probably related to their multi-organ dysfunction. So what risk adjustment should we be using? Well, if you're going to go ahead and bucket into surgical versus medical, I think the surgical risk models typically include a lot of the STS risk factors. And so there's several publications utilizing STS risk factors, STAT category scores, et cetera. And that would be my recommendation for risk adjustment. It's the medical patients that we still need a better model on. And I would say use PICSIM. I think is a valid tool. But I think more work needs to be done to try and better stratify and understand the patients based on their reason for admission, their presentation. So it means that we're going to be sort of slicing our onion deeper and deeper as we learn more. And I think it's something that is really the future of medicine. If you look at our PICU populations, our oncologic emergencies versus plain sepsis versus ARDS, those are very different patient populations, but we're trying to fit these models onto these very heterogeneous patient populations. And then we struggle with that in congenital heart disease as well because of different varying physiologic and anatomic states.
Great, thank you. I think we are at the end of our scheduled time. It's 4:30 Eastern time. So I want to once again, on behalf of VPS, thank you, Dr. Lasa, for sharing your insights with the group this afternoon. And thank you all for participating, and look forward to seeing you all at a future VPS spotlight. Have a great day. Thank you.
Thanks, everyone.